Hello friends, today we will learn electrodiagnosis reading a report. So this lecture is prepared in such a way that if you don't know how to perform EMG NCV, at least you will be able to understand how to interpret the EMG NCV if you have report in your hand. So let us understand with few examples of reports. So first we will understand for motor nerve conduction study. See this report. Confused what to read? Let us start step by step. This is recording from left common peroneal nerve. So here we are testing left common peroneal nerve. Recording muscle is EDB, that is extensor digitorum brevis. This potential is created whenever we are stimulating common peroneal nerve at ankle. And whenever we are stimulating at ankle, so whatever the parameters are recorded, those are explained in this table. Now, if we are stimulating at head of fibula, so this type of the graph will be seen. When we stimulate at head of fibula, so all the parameters we are getting, those are recorded here. Now, what is this? 3 millisecond, 5 millivolt, 84 milliampere. So, 3 millisecond, it is known as sweep speed. Means what? Horizontally 1 centimeter is equal to 3 millisecond in this graph. Then comes to 5 millivolt. So 5 millivolt, it is known as gain or sensitivity. So vertically 1 centimeter is equal to 5 millivolt in this graph. What is 84 milliampere? So 84 milliampere, it is the intensity when this potential was captured. In the similar way for second potential, that was because of stimulation at head of fibula. So it is 3 millisecond sweep speed. So that is horizontally 1 centimeter in graph is equal to 3 millisecond. 5 millivolt means it is vertically 1 centimeter is equal to 5 millivolt. And this potential is recorded at 64 milliampere. Now here you can see two vertical markers. You also observe two horizontal markers. So total we have 4 markers. First vertical marker. So it is giving value of latency. So in this example you can see it is 2.06 millisecond. Second vertical marker. So for that corresponding value you can see here, that is 9.11 millisecond. Now this is difference of these two, latency 1 and latency 2, or you can say it is the horizontal distance between two vertical markers. So it is nothing but 9.11 minus 2.06, so it is equal to 7.05. So that you can see in this example here as duration. So duration means it is nothing but it is horizontal distance between two vertical markers in this action potential. Now coming to two different horizontal markers. So vertical distance between these two horizontal markers, it is known as amplitude. So in this example you can see it is 4.35 millivolt. Now area means whenever you join all these 4 markers, two horizontal and two vertical, at that time whatever the area is covered by this rectangle or square, sometimes it is known as area. So in this example it is 9.55. Now when we are analyzing second potential, so that is because of stimulation at head of fibula, so you can see that latency is 7.01 and amplitude is 5.83. Now we have to identify the velocity. So for that we have to measure the distance between two stimulating points. That is commonly done with measure tape. So here in this example it is 210 millimeter. Generally we are measuring in centimeter, so that is 21 centimeter when we are performing test, but machine is asking in millimeter. That's why instead of 21 centimeter we are writing 210 millimeter. Now we have to identify the difference of proximal latency and distal latency. Clear? Now, proximal latency, so definitely it is because of stimulation at head of fibula, and distal latency, it is because of stimulation at ankle. Latency means it is time taken by impulse to travel from stimulating point to recording point. So here proximal latency, it is 7.01 and distal latency, it is 2.06. So when we go for subtraction, so it is 7.01 minus 2.06. So it equals to 4.95. So that is already mentioned here as difference of latencies, proximal latency and distal latency. Now we have formula for calculation of motor nerve conduction velocity. So it is distance between two stimulating points divided by proximal latency minus distal latency. Let us put the value. So it is 210 divided by 4.95 or 96. Then value will be calculated. It is 42.42 meter per second. So this is how we are calculating motor nerve conduction velocity. Now let us understand for sensory nerve conduction study. This is sensory nerve action potential. So here you can see latency 1 marker. So it is at 1.95 millisecond, that you can see in table also. This potential is recorded from right ulnar, as you can see in left upper corner, and just by the side of it you can see that it is recorded from 5th digit. So that is little finger, that is supplied by ulnar nerve, okay, for its sensory distribution. Now amplitude, so that is vertical distance between two horizontal markers, so it is 21.32 microvolt. Generally for motor nerve conduction, amplitude is coming in millivolt, and for sensory it is coming into microvolt. Now distance between stimulating and recording point for sensory nerve conduction study. For motor nerve conduction, it is distance between two stimulating point, when for sensory it is for distance between stimulating and recording point. So here it is 120 millimeter or 12 centimeter. Latency is already there, so that is 1.95. Now we have formula for the calculation of sensory nerve conduction velocity. So that is distance between stimulating point and recording point divided by latency. Let us put the value. 120 divided by 1.96. Answer is 61.54. So that is already calculated SNCV, that is sensory nerve conduction velocity. For motor nerve we need at least 2 points of stimulation. Why? Because the common component that comes in both the stimulation, that is neuromuscular junction and muscle, we need to exclude by subtraction. Why? Because it is including neuromuscular junction and muscle, and we need only nerve conduction velocity. But in case of sensory, there is no neuromuscular junction, there is no muscle. So whatever we are getting by the calculation for distance divided by time, it is nothing but velocity only in nerve. Now these are all different values for different nerves. You can have screenshot of this, and you can have for your record. So in this screen you can see for median and ulnar. You can see in table latency, amplitude and velocity. Latency, as we discussed, it shows the time taken by impulse to travel and to reach from stimulating to recording point. So if you have more latency, it is problem. It is suggestive of demyelination. Amplitude. So amplitude is giving you number of axons. So amplitude less is problem. Less amplitude is suggestive of axonal degeneration or axonal loss. Now conduction velocity. So NCV, that is calculated from latency only, obviously, as per formula. So if the latency is more, demyelinating changes are there. In formula of NCV, latency is denominator. So here there will be inverse relationship. So latency more is suggestive of demyelination, NCV less is suggestive of demyelination as per formula. So you can have screenshot of this median and ulnar nerve. You can have for radial, long thoracic, axillary, musculocutaneous and suprascapular also. You can have for peroneal and tibial. So all these are motor nerve conduction, study normal values. Now for sensory nerve conduction, study normal values. You can have median, ulnar, radial, okay, and lateral and medial antebrachial cutaneous nerve. Then other are of lower limb, superficial peroneal, sural, medial plantar, lateral plantar and posterior cutaneous nerve of thigh. Now we will see the different examples of this report. So let us start with conduction block. So you can see that this patient is having surgery over the calf region. So it is possible that nerve may be damaged between the knee and ankle. So what will be the finding in NCV? Let us see. Now this recording is for posterior tibial nerve. It is recorded from abductor hallucis muscle. It is by stimulation at ankle as well as at popliteal fossa, that you can read in the report. Now we have to compare the amplitude. Okay, so if we stimulate at ankle, amplitude is 15.21, and if we stimulate at popliteal fossa, amplitude is 3.33. So here you can see that amplitude, because of stimulation at popliteal fossa, it is quite less as compared to amplitude whenever we are stimulating at ankle. So 3.33, definitely it is less than 50% of 15.21. So if you have amplitude reduction more than 50%, okay, whenever you are stimulating proximally, as compared to distal amplitude, your proximal amplitude is less than 50%, or we can say that amplitude reduction is more than 50%. So that is suggestive of conduction block. Okay, let us understand with physiology also. For example, as we have seen that patient was having surgery in the calf region. So when you stimulate at ankle, so that part will be normal. But when you stimulate at popliteal fossa, so impulse will have to travel from this region where surgery is done. So definitely the amplitude will be less. So here the distal component is normal, but whenever the impulse is coming from proximal region, so it has to pass from this damage, so there will be amplitude reduction. So in short, if your amplitude because of stimulation at proximal side, if it is reduced more than 50% as compared to amplitude because of stimulation at distal side, it is suggestive of conduction block. Now let us see for facial palsy. So in this you can see that patient is having one side palsy. Now this is report for right facial nerve recorded from nasalis muscle. So we have to see the amplitude, so that is 2.72. Right side is normal for this patient. So 2.72 millivolt it will be considered as reference value. Now we have to compare this reference value with left side, that is affected. So on right side, that is normal side, it is 2.72 millivolt. On left side it is 0.66. So definitely it is lesser than 50%. So on the affected side, amplitude is lesser, more than 50% as compared to amplitude on normal side. In conduction block, we were comparing proximal and distal amplitude. In Bell's palsy or facial palsy, we are comparing amplitude of right and left side. So here affected side should be having amplitude lesser than 50% as compared to amplitude of normal side. Okay, in this also we have classification. If the amplitude is less than 10%, recovery may happen within 6 to 12 months. If the amplitude is coming 10 to 30%, recovery may take within 2 to 8 months. And if the amplitude is more than 30% but less than 50% as compared to normal side, so the recovery will be very good and you will be having recovery in less than 2 months. Now carpal tunnel syndrome. So it is very interesting. Here in this picture you can see that median nerve is getting compression okay, from this carpal tunnel. So it is getting compressed. Now let us see the report. So here it is taken from right median nerve and recording muscle is abductor pollicis brevis, and it is by the stimulation at wrist as well as elbow. So as you can see in latency 1, 6 millisecond it is latency. Ideally it should be less than 4.4 millisecond whenever you are stimulating 3 centimeter proximal to distal crease of wrist. Clear? So normally it should be less than 4.4 millisecond, but for carpal tunnel it should be more than 4.4 millisecond. Is this clear? So here we are getting 6 milliseconds, so definitely it is more than 4.4 millisecond. So it is suggestive of carpal tunnel syndrome. Now along with this we have to see the amplitude also. So amplitude is 5 millivolts, so that is normal. Okay, and velocity is 63.64 meter per second, so that is also normal. Why? Because here the stimulation is at wrist but 3 centimeter proximal to distal crease of wrist. Clear? So actually we can say that stimulation is proximal to compression. Another stimulation, that is at elbow, so definitely it is also proximal to compression. So here both the stimulating points, they are proximal to compression. Okay, and as per formula of MNCV, it is distance between two stimulating points. So when we compare or when we calculate this distance between two stimulating points, so it is pure nerve, and that will be 3 centimeter proximal to wrist. So that is also 3 centimeter proximal to compression. So definitely nerve conduction velocity and amplitude will be normal. Latency, why it is affected? Because it is the time taken by impulse to travel from stimulating point to recording point. Recording point is abductor pollicis brevis. Stimulating point is 3 centimeter proximal to distal crease of wrist. So impulse will have to travel from compression. That's why the latency is prolonged. Now we have to compare the values of median nerve along with ulnar nerve also of same side. Why? Because only latency prolongation in median nerve, it is not sufficient to prove that it is carpal tunnel syndrome. It may be in case of polyneuropathy also. But here we are proving that right ulnar nerve is normal. So it is not case of polyneuropathy. Clear? So we have to prove that right ulnar nerve findings, they are normal. Now here we have to see the latency for right ulnar nerve. It is 2.77 millisecond. Now there is one formula. So we have to give the difference of this latencies of median and ulnar nerve. So ideally in normal individual the difference should be less than 1.1 millisecond. For carpal tunnel syndrome, this difference of distal latency of median motor nerve and distal latency of ulnar motor nerve, it should be more than 1.1 millisecond. So in our patient it is 6.00, so that is nothing but latency of the median nerve, that already we saw in the previous page, and latency of ulnar nerve, so that also we have in this figure. Okay, so 6 minus 2.77, so difference is 3.23 millisecond. So normally this difference should be lesser than 1.1 millisecond. For carpal tunnel syndrome it should be more than 1.1 millisecond, and we have 3.23 millisecond in this example. So definitely this patient is suffering from carpal tunnel syndrome. Another criteria, we have to go for sensory nerve conduction study also. So here it is right median sensory nerve, that is recorded from second digit, that is nothing but index finger, where there is supply of median nerve. Here the latency is prolonged, that you can see amplitude is also reduced and velocity is also reduced. Why? Here the stimulation is 3 centimeter proximal to wrist and recording is again distal to wrist. So stimulation is proximal to wrist and recording is distal to wrist, that is from first digit. So definitely the impulse will have to travel from compression. And for sensory nerve conduction study we are not getting second point of stimulation. So here this is the only pathway that we are assessing. Okay, the point 3 centimeter proximal to wrist crease, okay, from that point to index finger. So definitely your latency, amplitude and velocity all will be affected. Now we have to prove ulnar nerve here also normal, because if the ulnar nerve is also affected, it is not carpal tunnel syndrome, it is case of polyneuropathy. Okay, so here again the difference will be having some role. Why? Because median is affected, ulnar is normal, so this difference will be always more. So for this sensory nerve conduction study, what is the difference that is allowed? So the distal latency of median sensory nerve minus distal latency of ulnar sensory nerve, normally it should be less than 0.2 millisecond, but for carpal tunnel syndrome it should be more than 0.2 millisecond. In our patient, median nerve latency it was 4.93, obviously of sensory median nerve, and sensory ulnar nerve latency it is 1.95. So 4.93 minus 1.95, it is equal to 2.98 milliseconds. So definitely it is more than 0.2 millisecond. So it is again supporting the diagnosis of carpal tunnel syndrome. Now foot drop. So here you can see in one foot the dorsiflexion is lacking. So let us see with the report. So here you can see this report is for posterior tibial nerve, recorded from which muscle? Abductor hallucis muscle. Here you can see that latency, amplitude and velocity, all these findings are normal. Now let us go for peroneal. So this is report for left common peroneal nerve, recorded from extensor digitorum brevis. So here actually the potential itself it is not generated. So it is suggestive of complete axonal degeneration in common peroneal nerve of left side. So we have to cross check with SF also, or opposite also you can do. Whenever you are having any case in which the surge Faradic current is not responding, so no need to send that patient for NCV. Why? Because if the surge Faradic current is not responding, definitely the potential in NCV will be also absent. Now in this patient only we have abnormal findings in common peroneal nerve. Now if you have also abnormal findings in posterior tibial nerve, so that is here, so if this is also affected, okay, and this common peroneal nerve that is also affected, so in that case what you need to do, you need to check sciatic nerve also. But in this case it is not required. Why? Because the tibial nerve is functioning properly, only common peroneal nerve is not functioning properly. Now in case of polyneuropathy, polyneuropathy means, poly means multiple, okay, and neuropathy means pathology of nerves. So multiple nerves will be affected, like in case of diabetic polyneuropathy, alcoholic polyneuropathy, in case of Guillain-Barré syndrome, all these are examples of polyneuropathy. So here you can see the report of posterior tibial nerve, recorded from abductor hallucis muscle by stimulation at ankle and popliteal fossa. So here the amplitudes they are normal, okay, so they are marked with green color, but velocity is reduced, so that is marked with red color. Let us see for other nerve. So you can see that right median nerve, so amplitude is also reduced and velocity is also reduced. Okay, so this is nothing but amplitude reduction, it is suggestive of axonal degeneration or axonal loss, and velocity reduction it is suggestive of demyelination. So it is suggestive of axonal degenerative and demyelinating type of neuropathy. Now what about this? So that is radiculopathy. Radiculopathy means throughout nerve is not having any damage, but it is getting compressed somewhere. Okay, it is getting compressed somewhere. Let us see. So for that we have F wave. So you can see that on the left side you have M wave. Okay, after that on the right side in the graph you can see you have F wave. So M wave they are seen at the gain or sensitivity of 5 millivolt, and F wave they are seen with the gain or sensitivity of 1 millivolt, and this whole graph it is at the sweep speed of 10 millisecond per division. Here you have to see the F mean. So F mean here it is 54.69. So for upper limb F-wave latency should be less than 30 millisecond, and for lower limb F-wave latency should be less than 60 millisecond. So here this is for posterior tibial nerve, so definitely it is lower limb. So for lower limb, maximum value of F-wave latency should be 60 millisecond. So here it is 54.69 millisecond, so definitely it is lesser than 60 millisecond. So here it is normal. Now here you can see it is H reflex. Okay, so on left side of the graph you can see M wave, and on the right side in the middle part of the graph you can see H. Okay, so M wave it is seen at the gain or sensitivity of 5 millivolt, and H it is seen at the gain or sensitivity of 500 microvolt, and whole graph is with the sweep speed of 10 millisecond per division. So here H latency you have to see it is 35.68 millisecond. So generally the maximum allowed value for H reflex when it is recorded from soleus, it is 32.5 millisecond. So definitely 35.68 millisecond, it is more than 32.5 millisecond, that is maximum allowed latency. So here it is suggestive of radiculopathy. Now let us see for EMG. So EMG, that is electromyography, so it is having insertional activity, means whenever the needle is going inside or getting inserted inside the muscle, at that time whatever the activity is seen, it is known as insertional activity. Another is spontaneous activity. So needle is already inside, therapist or examiner is not moving the needle, as well as patient is not contracting muscle, so it is known as spontaneous activity. Voluntary activity means needle is already inside the muscle and patient is moving the part or body part, so the muscle is contracting. In that case it will be with active movement, so that will be minimal type of the voluntary activity, and it will be with resistance also. Why we are offering resistance while doing EMG? So that is to recruit the fast twitch fibers. So whenever we are recording with resistance, it will be known as maximal type of the voluntary activity, and commonly it is known as interference pattern or IP. Now all these parameters you have to remember, you don't have any choice. Amplitude is ranging from 100 microvolt to 2 millivolt. Duration is from 5 to 15 millisecond. Rise time not having much clinical significance, it is lesser than 500 microsecond. Shape of this MUAP, that is motor unit action potential, may be diphasic or triphasic, and sound will be clear distinct thump as if something is falling on a hard surface, okay, or something is having free fall, and whenever it touches the ground, so whatever the sound comes, it is known as clear distinct thump. Frequency for normal individual, it is ranging from 30 to 50 per second, and in case of interference pattern, amplitude may reach up to 5 millivolt starting from 2 millivolt. Sometimes satellite potentials will be seen, so those are nothing but late and unstable potentials. Now in case of signs of denervation, when your nerve is getting degeneration, at that time what will be the finding? So presence of spontaneous activity, generally there is electrical silence. Okay, if your needle is going inside the neuromuscular junction, then even in normal individual you will be getting spontaneous activity. Second option, your patient is not relaxed, so in that case also, in case of normal individual also, you are getting spontaneous activity. But in all other cases, if the spontaneous activity is coming itself, it is abnormal, so ideally there should be electrical silence. Clear? So if you have presence of spontaneous activity, for example fibrillation potential, positive sharp wave, or fasciculation potential, or any other type of this spontaneous activity, itself it is abnormal. So in short, presence of spontaneous activity itself it is abnormal. It is giving signs of denervation. Some authors, they are also telling that in presence of signs of reinnervation also, this spontaneous activity will be visible. Now generally it takes time like almost 3 weeks to appear for this spontaneous activity, okay, and in upper limb even this abnormality is existing after 6 months in upper limb and after 18 months in lower limb, spontaneous activity will not be visible. So we can say that before 3 weeks, even if the patient is having abnormality, spontaneous activity will be absent. And for upper limb after 6 months and for lower limb after 18 months, okay, even patient is having abnormality, spontaneous activity will not be visible. In all other cases, presence of spontaneous activity itself, it is abnormal. It is either signs of denervation or signs of reinnervation. Now in case of myogenic lesion, so let us see this voluntary activity. So here you can see it is recorded from right tricep, okay, with the sweep speed of 10 millisecond per division, means 1 centimeter horizontally it is equal to 10 millisecond, and sensitivity or gain, it is 100 microvolt per division, means vertically 1 centimeter it is equal to 100 microvolt. So here also you can see the same thing, but the potentials, they are very small, but it is recorded from frontalis. So it is fine, because generally we are having 100 microvolt to few volts, okay, so generally up to 2 millivolt. So here you can see it is more than 100 microvolt, it is more than height of 1 centimeter, so definitely it is more than 100 microvolt. In case of this right tricep, you can see that they are occupying 5-6 squares vertically, so it is near about 500 microvolt to 600 microvolt. And in case of this frontalis, they are hardly occupying 1 or more than 1.5 square vertically, so they are hardly of 1.5 centimeter or more than 1.5 centimeter, but definitely less than 2 centimeter. So we can say that here the amplitude is ranging from 100 microvolt to 200 microvolt. This is example or picture of interference pattern. So this is again for right tricep, and sweep speed is 100 millisecond per division, and sensitivity it is 100 microvolt per division. So here you can see that many squares they are occupied, and generally the one square it is equal to 1 centimeter. So here we can say that this interference pattern, on some places they are occupying all 10 squares, so it is reaching around one square it is equal to 100 microvolt per division, means 1 centimeter 1 square it is equal to 100 microvolt per division. Okay, so it is occupying near about 10 squares, so it is reaching around 1000 microvolt per division or 1 millivolt per division. So this is just interpreting the report. Now you have to correlate all this with the clinical findings also. So it's not like that just by attending this lecture I will be master in this electrodiagnosis. This is just beginning of it. So just make this lecture as reference. Now start interpreting different reports, okay, discuss with your colleagues, then definitely you will learn, okay. With practice you will be able to interpret all the reports at one point of time. Clear? So just consider this lecture as reference. This reference is prepared from Electrotherapy Explained Principles and Practice, Clinical Neurophysiology by Mishra and Kalita, Electrodiagnosis in Disease of Nerve and Muscle by Kimura. Thank you.